Hi, welcome everyone that's coming into the room. So thanks for joining us this evening. I'm sure you had lots of other things and interesting shows to watch. So thanks for joining us. This is a talk that's really near and dear to me because the only grandparent I knew, the only one that was alive when I was a kid was my dad's mom. So she had diabetes, but it was poorly treated, and it was with many old drugs. So she died in hospital when she was just in her 60s from complications of diabetes. And a lot of people would have family members or relatives or loved ones that have had diabetes, and they might remember the complications and problems that they had. But this talk is intended so we can identify if you or your loved ones are at risk, how to identify it early, and to show you that there are many ways, many new ways that we can manage with lifestyle, working with your healthcare team, and some medications that can help manage diabetes so we can avoid the complications. So by the end of today's talk, you'll have a great understanding of what diabetes really is, that it's more than just sugar, but it doesn't mean that you have to be on insulin. And it shows you that we can still live healthy, happy, active lives, even with a diagnosis of a chronic condition. Because after all, every one of us, everyone in this room has a chronic condition, including me. It's incurable, it's inherited, but it's also sexually transmitted. And of course, that's life. But that's the beauty of being here as well. So we all have this chronic condition and some other ones added on as a bonus. So we all have some chronic conditions, but we can still be happy and healthy and active and connected to one another. I'd like you to reintroduce Leona. She's here every time because we wouldn't have the Empowering Patients program without Leona. So thanks, Leona, for all your support. And we have a special guest, Michelle Wilson. So she's kind of our special guest. So give us some really helpful information how Burnaby patients can get some more support in improving their lifestyle and improving their health as well. So stick around to the end, around 8:15. I'll try to end on time, but we will have time to answer any questions you have, and you can add them to the chat as well. So here's Leona.
Hi, everybody. Thanks for joining us tonight. We do have lots of helpful resources in Burnaby that I'd love to share with you. So I'm going to pop some links into the chat. I'll let you know what they are, including our Empowering Patients main page, which has all of our upcoming talks, including the registration links, and also recordings of talks that we've done over the past year. So if you've missed a talk and there's a topic that you're interested in, by all means, check that out. Dr. Wong is very generous in sharing the presentations for each talk. They're always updated every time, so they're very current for you. We include links to his presentations, as well as key points documents that you can download and share with yourself or just have on hand for yourself. So I'm going to pop that link into the chat. I'm going to pop the Burnaby Division Looking for a Family Doctor page. There is a substantial wait list in Burnaby, as you probably know, but we manage it here in Burnaby. So I'm going to put a link to that page in there, and that has a link to get yourself added to a wait list if you don't have a doctor. I'm going to put the Burnaby PCN, or Primary Care Networks, page into the chat, and that's got many resources, and Michelle will speak to some of those, but from social resources to senior resources to youth, yeah, so I'm going to throw that into the chat. There's another free health talk program that we do through the Burnaby PCN called Doc Talks. I'll share a link to Doc Talks, so there might be some topics in there that you're interested in exploring. There's recordings of those as well. And also the COVID Roundup. We're still doing that every week. It comes out every Friday. And what we do is we vet information on what's going on in the world of COVID for you. We put it into a simple newsletter format, and you can subscribe to that. So I'm going to put a link to the most recent one we did was November the 4th. You can have a read. So it is a couple of weeks old, but there will be a new one coming out tomorrow. And we don't have the information sheet and presentation updated on tonight's talk yet, but we'll have that done over the next day or so. And please, when we end the talk, there's a survey, just a few questions that we asked just to see what you thought of the talk and get your feedback. So please stay tuned for that. That's at the end. We have lots of time for that. That's it for me.
Thanks, Leona. So as you can see, Leona not only powers the Empowering Patient program, she has a lot of activity with the Burnaby Division of Family Practice. So she's one of the most wonderful people I've worked with for so many years since we founded the division. So just what is the Division of Family Practice? So it's a nonprofit association that's made up of the family doctors that serve the Burnaby community. And Leona mentioned the PCN, Primary Care Network. So that's an even greater initiative, which is a wonderful partnership of the Health Authority, of all the agencies, the City of Burnaby, the Burnaby Division, that really works together to try to create a kind of a seamless net to support all of us that live in the Burnaby community to live our best lives and have the resources we need so we can be emotionally and physically healthy and fit. So why are we here? So I always like to start with family doctors care not only about our individual patients, we care about our community. And that's really what the Burnaby Division says. And that's why we're here today. And we also care about the future of healthcare and the future of every one of you out there and the people that you can touch as well. So we care about our patients and we care about our community in what we do in outreach and working with our partners to support your well-being. So today I'll be talking about diabetes. I'll start off with just a different approach to health, which is not just the treatment of diseases or conditions like diabetes. So I'll expand on that. I'll explore some of the common myths about diabetes and in response to them, what the facts that we do know about diabetes, how to determine if you are personally at risk and if you should be tested for diabetes now or when, and what kind of things in blood tests and other ways of monitoring should people with diabetes keep track on a regular basis. And we'll talk about the basics of healthy eating for diabetes, or if you are at risk for prediabetes or the condition that predisposes to the diabetes in the future. Why exercise or physical activity remains really, really important in managing our health with or without diabetes. And just some tips on achieving your goals, no matter what they might be, regarding your health or anything other that you want to do to achieve your positive potential in life. So what is healthcare? I always start every talk like this, that if you watch television, a lot of it you see of healthcare is in the hospital, in the emergency. If you watch Grey's Anatomy, everything takes place in the hospital, except for the romantic things between the major players in the show. If you talk to community healthcare workers, to nurse practitioners, to home care teams, to PCN people, and to family doctors, we'll tell you that the bulk of your care is actually in the community, managing chronic conditions and doing preventive care. But who is the one person that provides most of your health care? So even if you do have a family doctor, it's not your family doctor, it's you, of course. We're here to support you. And you're the one that's in charge, but we do need to give you all the support and connect you to the resources you need. And that's really the backbone of this Empowering Patients public health program that Leona and I started quite a few years ago. I think we're going on to 8 years. I kind of lost track. So healthcare is self-care. And the best predictor of your future health are the habits you practice today. But just an overview of how I conceive that care you give to yourself. What you eat, what you do, how you feel, and how you relate. That first foundation is what do you put into your body, even the healthy things and the not so healthy things. And it also includes medications if needed. That second foundation is physical activity balanced by rest and sleep. And the third foundation is how you feel, emotional well-being, managing stress, recognizing your emotions and being able to manage them and find meaning. And the fourth foundation how you relate, healthy relationships. So a commitment to your most important relationships, being able to communicate your needs and to understand one another, and spending time together and nurturing unconditional love. So each of these 4 foundations have been topics of the Empowering Patients program, and we have videos on each of them and handouts from prior talks. And what do you need as an empowered patient for good self-care? You need knowledge, unbiased knowledge, because much of the information that we get is actually somewhat biased or a great deal biased, be it from Dr. Oz or from the daily news. There is some bias with someone always trying to slant things in a particular way. So that's why we put together this program from physicians, mainly myself for the content of these talks, but without with the importance of focusing on what you need to support your own healthcare and what questions to ask healthcare providers and where you can find support in the community. So that professional and support from peers. And of course, planning your healthcare. And again, the big question, what is health? So health, is it the absence of disease? Well, I disagree. Health is not the absence of illness, and healthcare is not merely the treatment of disease. I really believe that every one of us has a positive potential in life and in health. We each have a unique potential, and I think that unique potential is your gift to life. And it's our duty to realize that potential and to help others achieve theirs. So that's kind of my mission statement, but hopefully that suits yours as well. So your positive potential doesn't mean being perfect, because none of us are, but it is guided by your most personal, deepest, greatest values. So everyone's potential is different and guided by their own beliefs and what they're committed to. So 5 myths about diabetes. 1 is, I don't need to worry about it. 2, it's all about sugar. 3, it comes from being overweight and eating too much sugar. And that all people with diabetes need to take insulin and check their blood sugars throughout the day. So in case these things are scary, I reassure you, none of them is true. They're kind of an oversimplification, and sometimes from our experience with loved ones, like my grandma who passed away when I was a kid because of complications of diabetes and needing insulin. And a lot of the media makes you think that we're having a diabetes epidemic because of all the sugar and the fast food we have. But people that are consuming more sugar or eating more, we won't necessarily have diabetes. So we'll talk about why that is. And it's a lot more than just sugar. And that final one, everyone with diabetes will get complications. That's not true. And our goal is to support everyone that has the risk factors for diabetes to recognize it early and to team up with your healthcare provider, usually your family doctor and the whole team, so that you can manage the condition and live a healthy life and minimize the complications. So let's explore myth number 1. You don't need to worry about it. Diabetes is really common. In fact, 1 in 11 adults over 20 actually has diabetes, and they may or may not realize it. And the risk for diabetes generally increases as we get older. So if you inherit the gene for diabetes, as we get older, our metabolism changes, and it might be expressed at an older age. And if we become less active and gain weight, if we have that gene for diabetes, then we are more likely to develop it at a younger age as well. So 1 in 11 is pretty common. So if you're in a room with a dozen people, there's a good chance that you or at least one other person does have diabetes, but may or may not realize it. So average physician practice, we usually have about 200 patients that have diabetes that we're actively managing and supporting. Myth number 2, it's all about sugar. Well, sugar is an important part of it, but diabetes is really a problem of metabolism, how our body breaks down food, produces energy, and how that energy is used throughout the body, how we convert different food products into energy. And that powers every cell in your body, from your heart cells to your brain cells as well. So it affects every system. So glucose is the main source of energy for every cell in your body. Yeah, and therefore diabetes can affect every organ system, including the circulatory and nervous system. If diabetes is poorly controlled or the sugars are out of control, it can gradually increase your risk to cause heart attacks, strokes, kidney failure, even amputations of the foot or leg, and even blindness. So these are common things that we try to prevent with diabetes. Myth number 3, that diabetes comes from being overweight or just consuming so much sugar. If that really was the case, then kids right after Halloween would suddenly develop diabetes. And of course, their parents who bought all their favorite candies so that they can have the leftovers would all develop diabetes. But it's only if you actually have the risk factors that you might. And you may have heard there's 2 types of diabetes. We call it type 1 and type 2. So type 1 is the less frequent, which is called insulin-dependent diabetes. So this is when the pancreas, the organ deep in your abdomen, it produces insulin that helps your body break down and manage blood sugar. So the pancreas can, in some cases, no longer produce insulin, and therefore insulin injections or infusions of insulin are needed to manage the blood sugar. So this is the minority of type 1 diabetics. And this is the kind that might appear in a child, or can appear in a young adult, or sometimes less frequently at an older age, often when something causes the pancreas to no longer function. So it can happen after a viral illness that causes inflammation of the pancreas. Type 2 diabetes is much more common. As I said, it's the most common. 90% of cases of diabetes are the type 2. So it means your body has developed resistance to its own insulin. It is generally hereditary. There are some rare subtypes of that type 1 diabetes that are hereditary, but pretty well all type 2 diabetes is genetic and hereditary. Unfortunately, there's no specific screening test that we can do for screening for the genetics for diabetes. But if you do have one or more family member that has diabetes, like a mother, father, grandparent, or a sibling, or a child that has type 2 diabetes, it does put you at approximately 50% risk of having that gene. And therefore, in the right conditions, you may develop diabetes. So just having any family history is a good clue. And in this type of diabetes, the cells become resistant to the effects of your own insulin. You become intolerant of glucose, so that if you have the same amount of glucose, like a Slurpee or a yummy ice cream dessert, compared to if you didn't have diabetes, you'd be able to break that down and manage it without your blood sugars going too high, because your body is sensitive to its own insulin that's secreted by the pancreas when we have a meal. So with type 2 diabetes, that insulin doesn't work as well. The body becomes intolerant of it. And your body is really sensitive to carbs, carbohydrates, not just sugar, but starchy foods as well, including our favorites like noodles and pasta and bread and rice, which takes up a large part of most dinner plates. So these types of foods, these carbs, sugars, as well as the starchy foods, can cause a greater increase in your blood sugars with type 2 diabetes than it normally would. Myth number 4. All people with diabetes need to take insulin and check their blood sugars throughout the day. So that's not true. It is true for type 1 diabetics that there's insufficient natural insulin, so the extra insulin that you have to inject is required. And when we do that, then we need to check the blood sugars carefully just to make sure not going too high or too low in the blood sugars, because both those conditions could be potentially dangerous. People with type 2 diabetes, most, on the other hand, do not need to take insulin with the onset of their condition. Sometimes over decades as the condition progresses, or if the symptoms of diabetes are not recognized early, or someone doesn't do a screening test if they're at risk, sometimes the sugars are so high that insulin is needed if the sugars are dangerously high. But in general, if we catch this in the early stages, there is no need for insulin. And if you're not using insulin or taking any particular medications that will lower your blood sugar lower than normal, then you don't necessarily have to do frequent glucose testing throughout the day. So your healthcare provider, your nurse practitioner, or your family doctor would be able to tell you how frequently you should be monitoring your sugars, depending on what type of diabetes you have and what stage you're at. Regular exercise, at least 30 minutes each day, and more frequent regular meals with low glycemic index foods are really essential. So I'll explain that low glycemic index in a moment. So physical activity, regular frequent meals, and eating the right kind of carbohydrates or starchy foods are really essential for managing type 2 diabetes on or off medication. And there are a variety of oral medications that improve glucose tolerance and lower your blood sugars with type 2 diabetes. And as I mentioned, if sugars continue to rise over the years, insulin may be required. But for the majority of people with type 2, they will not need insulin. And the next myth, everyone with diabetes will get complications. So one of the big points of this talk is to recognize diabetes early, to know when you should be tested if you need to be tested, and knowing what to monitor so that we try to avoid or minimize the complications. With careful self-management, that's us coaching you and helping you manage your own condition, most of the complications of diabetes can be avoided. That professional support and education can enable every individual to be effective managers of their own health. So empowering you. So these are really important symptoms, but most people with diabetes will not get these symptoms. But these are the more dramatic symptoms that indicate that you actually have diabetes. So if you or a loved one might have these symptoms, it's time to see a healthcare provider and consider doing some blood tests. So the classical symptoms you read in books or online is unexplained weight changes. So either gaining 10 or 20 pounds or losing a great deal of weight for no apparent reason or change in your lifestyle might be a clue. Polyphagia is a medical word for excessive hunger in eating. So you can't satisfy your hunger. And then polydipsia is the medical term for excessive thirst in drinking. So you have an insatiable thirst because your blood sugars are so high that the sugar's coming out in the urine. It makes you urinate a lot more too. You probably only need 1 bottle a day. So classical symptoms are unexplained weight changes, excessive hunger, excessive thirst, and finally polyuria, which is excessive urination. So not the usual that a lot of older adults have, needing to wake up in the middle of the night to urinate a little bit at a time because the prostate is blocking the flow of urine, or after menopause, sometimes the urethra at the end of the bladder doesn't allow you to fully empty the bladder. So polyuria is actually urinating large volumes of urine, enough to fill a little wading pool. So excessive hunger, extra thirst, unexplained weight changes, and excessive urination. So if you have any of these or all of them, definitely you need prompt medical attention within a week at the most. But most new cases of diabetes are diagnosed before these dramatic symptoms appear. And then we have lots of opportunity to manage lifestyle and get the blood sugars under control and avoid those complications we talked about. So are you at risk for diabetes? So as I mentioned, if you have a family history of diabetes, particularly in your first degree relatives, like mom or dad, a sibling, brother or sister, or one of your children, if they have diabetes, then you're at increased risk as well, and you should be screened and tested. If you have a history of developing gestational diabetes, that's diabetes that arose during pregnancy, or certain conditions like polycystic ovary syndrome that often young women will develop, it's a metabolic condition that increases your risk for diabetes in the future because it's similar genetics. There's a condition called metabolic syndrome that is associated with higher blood sugars, higher cholesterol and triglyceride levels, increased blood pressure, and accumulating fat around the abdomen. So when we get extra body fat around the abdomen, it's not from being lazy or just eating too much. There are genetic conditions like metabolic syndrome and diabetes that predispose to difficulty losing that extra fat that's more visceral, right within the organs of the abdomen. And pretty well every minority ethnic group, Aboriginal, Hispanic, South Asian, East Asian, and African descent, we're all at increased risk because of genetics for diabetes as well. And of course, if we've gained weight and we're sedentary, then you may be at increased risk as well. And of course, with that metabolic syndrome, if you have high blood pressure or high cholesterol, and if you're over 40, those all increase your risk as well. So these risk factors are calculated with a few other factors in the Canadian Diabetes Risk Questionnaire called the CAN Risk Calculator. So you can go to the Canadian Diabetes Association's website and just take the test. And it factors in these risk factors in your age and your gender. And you can come out with if you're at low, medium, or high risk for diabetes. And that can guide you on how frequently you should be testing. So current guidelines on the Canadian Diabetes Association, that's a nonprofit that supports both individuals with diabetes as well as healthcare providers who are looking after them. So they issue periodic clinical practice guidelines. And their latest guidelines still recommend screening every 3 years in individuals over 40 or those who are at high risk using a risk calculator, like the CAN risk calculator. But if you suspect diabetes or not sure, consult with your healthcare provider, generally your family doctor who knows your history and knows your family history. We'll be able to arrive at when we should start testing for you. And the way we test is actually through 3 different types of blood tests. An easy one is number 1, hemoglobin A1C. So hemoglobin refers to our red blood cells. And the A1C is just a shorthand for the percentage of glycosylated hemoglobin. So that's sugar that's attached to red blood cell or hemoglobin molecules. So red blood cells live for 120 days. So that percentage gives us an idea of how high the blood sugars have been relative to normal for the previous 3 months or so. So it kind of gives us a good idea of how the sugars have been in general. And it's a test that does not require fasting, so it's much easier to do. The second test is the standard fasting glucose, like going into the lab when you haven't had anything for breakfast, including any sugary drinks or coffee. You can have water, but this is a test that's generally done in the morning, and they take a single sample of blood and checks your blood sugar level. And then there's the glucose tolerance test. We usually use this as a confirmatory test if either number 1 or number 2 are elevated. And that's where sugar is given to you when you're in the fasting state. And then we see what happens to your blood sugars over 2 hours with a load of 75 grams of glucose. So if that first number, that hemoglobin A1C, is over 6.5%, that meets the criteria for diabetes, as does a fasting glucose that's over 7.0. And the glucose tolerance test will measure your fasting glucose again. And of course, if it's greater than 7.0, or if after 2 hours of consuming that 75 grams of sugar, which is like a super Slurpee, if your blood sugar is over 11.1 2 hours later, then it shows you that your body isn't producing or responding to insulin such that you'll have a normal blood sugar level after. So when things are functioning normally, often that blood sugar 2 hours after consuming the sugar is back to normal, or it might even be lower than the fasting state, just due to your body's natural normal metabolism. So the main tests are that hemoglobin A1C, non-fasting, and the fasting glucose. And if those are abnormal, then we go right to the glucose tolerance test. To prevent diabetes, we try to maintain a healthy weight, because if we do have the gene or risk factors for diabetes, that extra abdominal fat makes our body more resistant to its own insulin and not be able to manage normal carbohydrates. As I mentioned, we try to reduce that abdominal fat through diet and exercise. And we can also eat more frequent, smaller meals rather than the intermittent fasting, like not eating all day and just having one big meal is not a great thing for people at risk for diabetes or people with diabetes. So intermittent fasting is not generally recommended by physicians for people that do have diabetes, because you want to even out your blood sugars and prevent highs and lows. Okay. And when we're eating those smaller meals, we'll be talking about what glycemic index is, the type of carbs you should be consuming. And of course, physical activity. It doesn't have to be painful exercise, but physical activities like working around the house, gardening, doing vacuuming, doing the laundry, those are good physical activities to do after you've consumed a meal or snack. So everyone with diabetes should know their numbers. That's kind of a slogan that we use for the Canadian Diabetes Association. So these are the things that anyone with diabetes needs to know about their regular lab tests. So these numbers include that hemoglobin A1C. We actually check that every 3 months for people with diabetes to ensure that the blood sugars in general have been in the optimal level over the previous 2 or 3 months. We check the bad cholesterol, LDL cholesterol, that's associated with heart disease and strokes, as well as HDL, or the good cholesterol, that protects your arteries and prevents strokes and heart attacks if it's elevated. We look at the ratio between your total cholesterol and that good cholesterol, the HDL ratio. So the higher that is, the higher your risk for heart disease. We do urine samples that checks for traces of protein called albumin. So we call that the microalbuminuria test. And we monitor the blood pressure, and we monitor the kidney function through a test called the GFR. So that first test, the hemoglobin A1C, gives us kind of an average glucose level. But the number you get on that lab test is not really what you can equate to what you would get if you poke yourself with a monitor. It does not require fasting, so it's a really convenient one for screening. And the goal is to have it less than 7.0% to indicate management of diabetes and blood sugars to reduce the complications. So we know that if we keep the sugars below 7.0%, it reduces the risk for having changes in this tiny blood vessels in the back of the eye that can contribute to vision loss and blindness in people with diabetes. So it's one of the most preventable causes for blindness is managing diabetes. So as I mentioned, that hemoglobin A1C is not equivalent to a glucose level. So glucose levels in Canada are measured in millimoles per liter. So those are the kind of numbers you would get from a glucose monitor, the millimole glucose level. And I'll give an example of that. So a hemoglobin of A1C of 6.5%, just at the level to diagnose diabetes with our current CDA guidelines, actually corresponds to a mean or average glucose level of 7.2 millimoles per liter. Hemoglobin A1C higher at 7.0%. Again, that's the threshold we aim to keep the blood sugars below, unless it's an older adult, like over 80 with diabetes. We tend to be more liberal and allow the A1C to range between 7.0 and 8.0, just to minimize too low a blood sugar. So 7.0% for the A1C is equivalent to an average mean glucose of 8.1, so quite a bit different in number. And an A1C of 7.5% gives you a mean glucose level of 9.1. So sometimes these numbers are confusing with patients that are monitoring their sugars using millimoles, because it doesn't correspond to numbers they've seen when they see that every 3-month hemoglobin A1C. So they're different measures. So it's good to know what's normal and what's the goal for each, the hemoglobin A1C, as well as your fasting or daytime sugars. So as I mentioned, the optimal hemoglobin A1C for adults under 80 years of age is 7.0%. And as I mentioned, usually corresponds to your before meal sugars, like before breakfast, lunch, and dinner, with sugars that are under 7.0 millimoles per liter, but not quite the same as the average sugar, which would be more like 7.2. And 2 hours after eating a meal is a common time we might check blood sugars. And the goal is to have it below 10.0. So for before and 2 hours after glucose levels with our test strips or with our strap-on monitors, if they're falling within this range, under 7.0 before each meal and under 10.0 2 hours after each meal, it usually will give us a predictable A1C that's in the healthy range under 7.0%. So This is what I just mentioned. Our goal before meals, 7.0 or less, and 2 hours after meal, under 10.0. Okay, but that's only if we can safely achieve it without causing too low a blood sugar, because some of our medications and insulin can make the sugars too low, and that can cause confusion, lightheadedness, and it can be life-threatening at times. Going back to cholesterol, LDL, or low density lipoprotein, represents what we call the bad cholesterol because it's associated with plaque, cholesterol plaque that builds up in our arteries. And that plaque can clog any artery. It could be going to our extremities like the feet. And if it's extreme narrowing, it can lead to poor circulation in the foot. And at the very extreme, even amputations of toes or feet may be required. Again, not likely to happen if we catch diabetes early on and teach you how to manage your blood sugar levels. It can clog the arteries that are within the heart itself that feed the heart muscle. We call them the coronary arteries. If those get blocked, we might get chest pain in the form of angina, or we could suffer a sudden heart attack where heart muscle dies downstream from the blocked artery. If the plaque is in the blood vessels, like the carotid, vertebral arteries, or within the brain itself, it can cause a stroke. And if it's for the tiny blood vessels called capillaries that feed the kidneys, it can lead to kidney failure. And the goal for the LDL cholesterol for most people is under 2.0 millimoles per liter. And normal is 3.6 or less. So for diabetes, because they're considered at increased risk for vascular disease like stroke or heart attack, we aim for a goal of 2.0. People who have had heart attacks or have known heart disease, we actually aim for even 1.8 millimoles per liter. So the opposite of the good cholesterol is the HDL, high density lipoprotein, which is the good cholesterol because it reduces that plaque that clogs up the arteries. It can be raised by healthy types of fats, like most nuts or seeds, or fish and fish oils, olive oil, and exercise. I put alcohol in brackets because alcohol does raise the HDL, but that's not the usual way we want you to do it, because alcohol has lots of ill effects on our bodies and increases cancer risk as well. So the goal for the HDL cholesterol is for men over 0.9 millimoles per liter, and for women over 1.1 millimoles per liter. So that's kind of our goal. And that can be increased with medications, but also with cardiovascular exercise, like brisk walking, swimming, running, cycling, pickleball, and healthy eating the healthy fats and oils. So not all fats are bad. As a reminder, there are healthy fats that we need for body function and cellular well-being, and to raise the good cholesterol and reduce your stroke and heart attack risk. And we talked about that ratio of the total cholesterol, which includes good and bad, divided by the HDL or good cholesterol. So of course, we want this risk factor to be low, generally less than 4.0. So it's a measure of cardiovascular risk, taking into account both the good and bad cholesterol. And the microalbumin was that test checking for trace amounts of protein in the urine, because it's associated with potential early kidney disease. We call it microvascular disease because the kidneys are fed by very small blood vessels. And so they give us an indication what's happening in the tiniest blood vessels of the body. And some of those tiniest blood vessels are also in the back of your eye, in the retina. We also like to monitor your blood pressure. When you have type 2 diabetes, the goal is a blood pressure less than 130 or less than 80, 130/80. It's a separate risk factor for vascular disease. So because people with diabetes in general are considered to be at higher risk, we want to reduce all the other risk factors like high cholesterol and high blood pressure, and if you smoke, to help you stop smoking. The GFR stands for glomerular filtration rate, and it's a measurement of the kidney function. So the doctor might check off something called creatinine, which is a blood test. That gets converted by the lab to the glomerular filtration rate, or the GFR. And normal is generally over 60, although it's also based on other factors like your age. So we watch that and monitor that pretty regularly to make sure that diabetes is not affecting your kidneys. So these other things are very important when you have type 2 diabetes or type 1 diabetes. So most people with diabetes should have a complete physical, at least every couple of years, just to check for complications of diabetes. So it would include a foot exam by a physician pretty well every year, because we're checking to make sure that your sensation, your nerves are functioning fine. Because diabetes can cause a neuropathy where you can lose sensation or even have what we call neuropathic pain, pain that's caused by nerve damage or malfunction. So a lot of people with uncontrolled diabetes might lose sensation in their feet and not realize that they would have something that would otherwise be a painful ulcer or sore in the bottom of the foot that can become infected. So everyone with diabetes should be carefully inspecting their feet, making sure they haven't stepped on a nail and they didn't realize it, or to make sure they don't have an infection around a toenail or the bottom of their foot where they can't see. And then, of course, everyone with diabetes, it's recommended that you have an eye examination by an optometrist or an ophthalmologist. And that's where they put in drops to dilate your pupils so they can look at the retina. That's the back layer of your eye that's so crucial for good and sharp vision. What we're looking for is the effects of blood sugars on the blood vessels of the retina. Because in type 2 diabetes, we often get excessive vascular growth, the red blood vessels in the back of the retina can grow and then cover up the nerves and reduce your vision. So every 1 or 2 years, and more often if there's some signs of what we call retinopathy or retina disease already. So both optometrists and ophthalmologists are equally qualified to examine your retina, but it requires that dilated exam. So how should you eat when you have diabetes? So as I mentioned, don't skip your meals or fast for long periods of time. Don't eat just one big meal in the morning or one big meal at nighttime. It's better to keep those sugars even with frequent smaller meals to keep the glucose at a nice, safe level. We'll talk about healthy portion sizes and we'll talk about glycemic index, as I mentioned earlier. So these portions are actually part of the Canada Food Guide for everyone, even if you don't have diabetes. So the Canada Food Guide, the latest version, recommends that half of our plate be vegetables. A quarter of the plate should be those starchy foods like the rice, potatoes, or pasta. For people with diabetes, we need to pay attention to those starchy foods that have a higher or lower propensity for making our blood sugars high after we consume it. We call that the glycemic index. 1/4 of your plate should be protein, and that could be the form of lean meat or fish or beans or nuts. And of course, we have to keep in mind the cholesterol part because animal meat tends to have higher cholesterol, and we want to keep that low in type 2 diabetes and type 1 diabetes. Most people with diabetes can manage one portion of fruit, like one apple or one banana or half a cup of berries, but not combining them together. So that for most people is enough so that they can burn it off if they're having that as part of an otherwise healthy meal. And we try to avoid simple sugars like pop and juice, because that's like having a whole smoothie full of 3 or 4 oranges and a banana and an apple all together. And it's so easy to just gulp that down in a few seconds and instantly make the blood sugar too high, higher than we can bring down with exercise. So half the plate veggies, a quarter of the plate starchy foods, but choosing the right ones with low glycemic index, a quarter with lower fat protein, and you can have a snack of 1 fruit portion and avoiding sugary drinks. Better to drink water or tea or coffee without cream and sugar, or just a bubbly drink that doesn't have a lot of sodium and no added sugar. But also pay attention to labels. So even though your juice or drink says no added sugar, there's natural sugars that are in fruit juices as well. So here's just another illustration from Canadian Diabetes Association and paralleled in the food guide. Like you might have milk or alternatives or even just water. half the plate vegetables, a variety of many colored vegetables is even better for all the nutrients and vitamins it provides. And of course, a quarter of the plate would be the grains or starches like bread, potato, rice, corn, or pasta. And a quarter of the plate would be lean sources of protein like lean meat, fish, chicken, beans, and lentils. So that glycemic index refers to the ability of a food to raise your blood sugar. And in general, for diabetes or someone prone to diabetes, we try to consume low glycemic index foods in preference to high glycemic index foods. So you can get a lot of detail from that Canadian Diabetes website, diabetes.ca. And a handy book you can get from the library is the GI Diet. It's actually useful to buy a paperback version as well, because it actually shows you the red light, high glycemic index foods that you should avoid to prevent your sugars from going up too high. The ones you should be cautious with, I'll give it a little yellow light to indicate that. And the green light are those that are generally low glycemic index. They're pretty safe to eat in reasonable amounts without making your sugars too high. So I recommend looking at the GI glycemic index diet by Rick Gallup. So there's many different versions and editions available. But I would recommend, if you do have diabetes or at risk for it, that you buy a paperback version so you can carry it with you when you go to the restaurant and when you go shopping. So examples of low glycemic index carbohydrates or starchy foods that have a low index in terms of number. So these are the ones we can choose more often. So in terms of breads, it would be more the 100% stone ground whole wheat, or heavy mixed grained whole wheat or pumpernickel would be good choices. For cereal, more like all bran or oat bran would be better. And for grains, barley, bulgur pasta noodles, parboiled or converted rice. And for potatoes, sweet potatoes, yam, and legumes like lentils, chickpeas, kidneys, split peas are generally lower glycemic index. So having those more often for that quarter plate for the carbs on your lunch or dinner plate. The yellow light or medium glycemic index foods, we could choose those more often than the ones on the right, which are high glycemic index. So that's whole wheat bread and rye and pita. So these will make your sugars go up a little bit faster than the low glycemic index foods, but generally good to eat in moderation. Basmati rice is way better than white rice, and brown rice and couscous are good alternatives as well. And then oatmeal, quick oats, puffed wheat are reasonable alternatives for cereal. So medium glycemic index potatoes would include the newer white potatoes. It can include popcorn, wheat thins, rye crisps. And on the right column, the high risk, high glycemic index foods are ones that we should eat less often, like highly processed white bread. Kaiser rolls and bagels tend to make our blood sugars go up faster after we consume them, particularly if we do have diabetes. And of course, a lot of commercial cereals like Rice Krispies, Corn Flakes, Bran Flakes, all the fun ones tend to be higher in glycemic index and make your sugars too high. And of course, avoiding that short grain white rice, which makes the sugars go up much higher than more fiber-rich brown rice or basmati rice. And the typical russet baking potatoes are higher in glycemic index, so we should minimize those, as well as French fries and pretzels and rice cakes, which, though low in calories, has a tendency to make our sugars go higher. So people may find, if they do have diabetes or the metabolism that makes you pre-diabetic, simply switching from high glycemic index to low glycemic index foods will still satisfy your hunger just as well, but you'll find that your energy is better and you might actually lose weight without consuming less calories. So that's the magic of knowing how our body tolerates and manages sugars. So not all of the foods that are high or low in glycemic index are intuitive. In general, we say that if it's highly processed, it's more likely high glycemic index, and we should avoid it. And if it's less processed, like whole wheat bread or brown rice, that's in general better for us as well. But do look at the GI diet and the details about the glycemic index on the Canadian Diabetes Association website. Physical activity, it doesn't have to be painful exercise, as I said, is really important for managing your blood sugars as well. So a general guideline is that everyone in Canada, if they're able to, should do a total of 150 minutes of moderate physical activity or exercise per week, or about 30 minutes a day that you could break down into 15 minutes twice a day, for example. So really manageable, enjoyable walks that you can do. Or even chores around the house can get your heart rate up and help you burn calories as well. But as I also mentioned, it's good to do some physical activity after your bigger meals, lunch and dinner, so that you can burn off that sugar, so that within 2 hours, it's in that optimal range. So we ask a lot of our patients when they're diagnosed with chronic conditions to eat in a different way, maybe take some medications, maybe change or start some new forms of exercise or physical activity. So I used to give doctor's orders and then be disappointed when I see the patients 3 or 6 months later not having started the medications or not having continued their exercise or improved their diet. And I realized that the goal should not be the doctor's goal, but it should be the individual's, so the patient's goals. So it's a collaboration. We're there to support you as healthcare providers, as your family doctor. We have recommendations which would be healthiest for your condition, but we do know that you are your primary healthcare provider, that you need the support and knowledge to achieve your goals and not necessarily our goals. So number one rule about achieving any goal, be it increasing exercise, improving the diet, or anything else you're working on, is to choose wisely and choose a goal that matters to you, that's aligned with your passions. And sometimes our most important values, like being there for our children and grandchildren and our partners and spouses and loved ones and friends, we need to look after ourselves, like getting enough rest and getting exercise so we remain healthy, so that we can enjoy time with the people that matter most to us, and to be there to help them when they need help as well. So often the most important things to us can be tied into ways of improving your health as well. It's really important to visualize yourself having achieved your goal. So kind of like the power of attraction, but it's really priming the pump for success in your own mind. So patients will come to me every day, bringing 1, 2, 3, sometimes 5 problems at one time. Hence the burnout of many family physicians. But I always try to turn things around. So addressing the problems that they present, but turning some of those problems like stress and anxiety or their weight, being overweight or unhappy weight, to a goal. So turning it, what's the opposite? So I always remember Roget's thesaurus that he used in elementary school. So it's not a dictionary, it's actually a book of antonyms and synonyms, words that mean the opposite or the something similar or the same. So I didn't realize until later in life that Roget wrote his book of his thesaurus of antonyms and synonyms because he was depressed and he wanted to feel happier. So he thought of words that meant the opposite of being sad and lonely after he had lost some loved ones. So it was feeling engaged, feeling at peace, feeling joy, would be the opposite of what he was feeling. And he found that it made him feel better. But we should turn our problems into goals. So visualize yourself being as active as you'd like to be, full of energy, feeling in control of your health, eating a healthier diet and feeling so much better for it as well. So visualizing yourself in a short time, a few months or a few weeks from now, having achieved your goal, really helps you focus and makes sometimes the difficulty of acquiring new habits much easier when you're visualizing that success. Break down the big goals, that big mountain, into small little morsels or molehills. Because if your goal is to run the sun run and you haven't even been walking around the block, you may quickly get injured, or you might procrastinate just because it seems so different from what you're able to do. But if you make your goal of being physically more active, just to walk 15 minutes once or twice a day for the next week, that might be much more manageable for you. So break it down into something that you can manage. And after a week or two, having achieved that goal, your confidence will be improved and you'll know that you can do a little bit more, And before you know it, you may surprise yourself what you can do in 3 or 6 months. So break down those big lofty goals into something that's manageable to gain confidence. And once you have that little goal, write it down, write down the details, because that tends to increase our chances of success as well. And those details are the SMART goals, or in Burnaby, we call it the smartest goals, because of course we have to do better than smart and smarter. S stands for specific. So be very specific. It's not just losing weight or doing more exercise, but specifically what are you going to do? Like, I'm going to go for a walk and I want to do something that's measurable. That's the M. How much or how often or how long? 15 minutes or 2 blocks or 1 mile, and how many times a day or how many times a week. A stands for achievable, has to be realistic and doable. So turn that mountain into a molehill, as I mentioned. And R means relevant. So it has to be important to you. As I mentioned right at the beginning, it has to be aligned with what counts for you, your values, your goals. And T is for time frame. When are you going to start, today or tomorrow? And when are you going to finish this little plan to adopt this new goal? And before you evaluate, looking at how you did, what did you learn from this exercise? And then S, stepping forward, what are you going to do next? How are you going to, what's your next molehill? What's your next little goal that you'll achieve? And what will you do differently from what you learned from this exercise? And then finally, T is for together. Who will you work with? Who will you share your success with? Because we do know that if we share our goals with one another, we inspire one another, and we also inspire ourselves, because we know we're responsible for someone else, that we don't want to let our loved ones down. It's important to anticipate potential roadblocks. So you might have the ambition of walking just 15 minutes every day, and that's doable. But what if tomorrow morning it's all foggy and it's not safe to walk a block, or if it's pouring rain? So anticipate the roadblocks and find alternatives, what you'll do in case of rain, in case of snow or fog. How will you get your physical activity done, or how will you achieve your goal? So planning ahead. So rains a lot in Vancouver, so we should be able to bundle up, have a bright yellow or orange raincoat so that other people in other vehicles can see us as well. Having nice boots so we don't get soaked, dressing warm enough, carrying a flashlight where it might be getting too dark, and to find places where it's safe to walk. Maybe even the shopping malls if it's not crowded and you're wearing an N95 face mask to prevent the flu, influenza, or COVID-19. And enlist support from other people. You might need a coach or a teammate or a partner, a friend, a neighbor, or your family doctor. We all will support you in achieving what matters most to you. So back to our positive potential. This is my kind of philosophy for healthcare medicine since I started practice. I believe we each have a unique potential, which is our gift to life, a gift to the rest of the world. And it's our duty to realize that potential and to help others achieve theirs. So that's actually my whole point in being a family physician, because I'm able to connect and engage with individuals and families over a lifetime, learning their values and what matters to them, and recognizing their strengths, that we can support them through the tough times in life and the diagnosis of a new chronic condition, and to show them that they can still achieve their unique potential. And it's our goal to support one another, because none of us is a separate individual, that we find meaning and we find joy and happiness in our connection to one another. And with appropriate knowledge, engagement, and support, we can manage chronic health conditions like the one we all have that I mentioned earlier, and we can live well and feel well. So just a reminder, the most common chronic condition, every one of us has it, it's incurable, it's sexually transmitted, 100% mortality, and that condition is life. Let's make the most of it. So at the end of each of these talks, I really urge each of you, if you've learned a few points that are useful, please share those points with the people that matter with you, because we're all part of creating a healthier community and supporting one another in health. So that's why we're here, expanding that circle of caring. This is something my mom taught me, is that she cared about her own family, but she cared about friends and our church community and people in the Burnaby community. And it's because of people like my mom and each of you that we look after our future, those that come after us. And as family doctors in the Burnaby Division of Family Practice, we're here not only to support the people in our community and our patients and our colleagues, we're trying to foster more doctors, family doctors caring for more individuals in the future and setting up networks of care through the primary care network so that we look after each other. So everyone, we want to create a community where everyone has a sense of belonging and that no one feels alone. So again, remember that secret, healthcare is self-care. So please pass on what you learned from our talks with the Empowering Patients program. We'll keep on revising and updating and bringing in some new talks. And the next talk next month is, I believe, is achieving your positive potential, or how to create new habits and positive change. So it'll be listed on our website as well. And I have my own blog if you want to read more about achieving your positive potential, emotionally, socially, and physically. So it's on my blog at davicuswong.wordpress.com. And again, the Burnaby Division website, which has a wealth of resources, and our Empowering Patients page is at divisionsbc.ca/Burnaby. So I think I will stop sharing and I'll invite Leona to come back on and introduce our special guest, Michelle.
For sure, for sure. This is such a good bio, Michelle. I hope you don't mind. I'm going to read it verbatim because it really captures your experience. So Michelle is a clinical lead with our PCN. She has worked in education, healthcare, and community settings supporting individuals living with complex health conditions and diverse abilities. Her training and experience is in behavioral change support and social emotional learning. This influences how she works as she encourages individuals to be self-determined so that they may thrive and flourish. Her collaborative approach seeks to help clients find creative solutions and support their ongoing skill development. She has expertise liaising between allied healthcare teams and creating partnerships with community organizations. She values meaningful connection and relationship building through kindness, compassion, trust, and respect. With a family history of chronic illness, she understands that change is hard. She is passionate about removing barriers and empowering individuals on their wellness journey. And for a fun fact, she's a prairie girl, as am I, and she loves to travel and being in nature, and she's an artist. So she's very well-rounded, and we're really happy to have her here. So I'm just gonna give you the floor.
Thank you so much. Just gonna set myself up here. So hi, everyone, and thank you, Leona, and thank you, Dr. Wong. It's such a pleasure and honor to be here with you this evening. So yeah, and Dr. Wong, we have something in common, unfortunately, but that's losing our grandmothers to complications of diabetes. So this topic is also very near and dear to my heart. And I'm really excited to share a little bit about our service with everyone here tonight. You're going to see that our approach is very in line with what Dr. Wong was sharing with you about managing health and well-being. So first, just a quick overview of who we are. So Be Well we're a fairly innovative new service that's offered in Burnaby, and we offer lifestyle and behavioral health coaching using an evidence-based holistic approach to support individuals in making small, manageable, and self-directed steps to improve mental and physical well-being, and to reduce the onset and progression of chronic disease. So to be eligible, you need to be referred by a Burnaby family physician or nurse practitioner, 19 years or older, at risk of developing chronic disease or with mild to moderate chronic disease, and would benefit from lifestyle changes. Some of the common reasons for referral are definitely obesity or overweight, pre-diabetic or diabetes, hypertension, high cholesterol, risk for cardiovascular disease, and sedentary lifestyle. Some common reasons for ineligibility or a potential redirection of maybe needing another service before coming to join Be Well would be if a person has mental health concerns and in need of a more targeted intervention, or physical concerns in need of targeted support, such as something like chronic pain management, or maybe alcohol dependence, things like that, binge eating disorder, or some significant cognitive impairment. So we work with patients to assess needs and barriers to healthy lifestyle choices, and then we work together to develop a customized health plan. We really believe in meeting people where they're at, and to try to offer a very non-judgmental service, supporting people with making those long-term gains. We really want to help think about making changes that are sustainable and maintainable. We're actually a team of 6 health coaches with the PCN in Burnaby under the supervision of a clinical psychologist. And we provide patients with up to about 18 months of support, depending on the need. And that includes our core coaching service of different content sessions, which I'll share with you. And then we also have a long-term maintenance program for up to 12 months once people complete the initial core service. And another thing is that something that we learned, we actually launched our service during the pandemic, so we were kind of forced to work virtually, and now we're really fortunate to have 2 offices open in Burnaby, one in the Hastings-Brentwood neighborhood and one in the Edmonds neighborhood. So we are able to see people in person, but we still have virtual as an option because we've recognized that is actually very convenient for a lot of people. So our service was developed initially by Dr. Leslie Lutz. She's the founder of the Small Changes approach that we use and Be Well. She's done 20 plus years of research and science going into this. So again, we are an evidence-based service. And a quote from Dr. Lutz is, "People don't need another diet. They need us to radically change our approach towards effective treatment so that it is realistic, sustainable, generalizable, and encompasses the whole person so that it can help them improve their health and well-being." And so we know that science tells us there's no one right path to health. We use the small change approach to meet individuals where they are at. We work collaboratively in assessing their unique needs and barriers to healthy lifestyle choices. And together we create customized plans tailored to the individual needs. So we really start by first understanding current patterns, and then we provide the skills and ongoing support to help set small, manageable goals relative to current patterns. What really sets us apart from other traditional programs is that we really are not about a quick fix. We're not a diet or a temporary way of life. We are about long-term maintainable changes. So the key is really to help individuals find what works for them in a sustainable way. We're all unique humans, and what works for one person doesn't necessarily work for the next person. So it's not a one-size-fits-all approach. We know that that doesn't work. We understand that change is hard. We're here to provide encouragement, instill hope, and offer new ways for patients to care for themselves in that non-judgmental way. So what small changes is about making lifestyle changes, moving toward food that nurtures you and brings you joy, moving towards activities that make you feel better and increase your energy and improve stress management, learning to separate food and emotion, dealing with every situation as a choice, getting rid of the diet rules, addressing other factors such as social support, relationships, how we think about ourselves, and cues that form our habits. So this is a list of the topics we actually explore with individuals when we're coaching. We have a really great workbook that we go through together on these different topics. And it's very interactive and gives you an opportunity to learn and to reflect and set your goals. And yeah, it's a nice complement to the work that we do together. Ultimately, these sessions are here to help individuals be more self-aware and provide strategies to help make more conscious and informed choices related to health and well-being. And again, really focusing on that self-care, right? We really believe in filling our own well, replenishing that and making that a daily practice. So just a little bit about some of the outcomes that we've been showing with our service. Even though we're not technically a mental health service, we do see improvements in mental health outcomes. So as you can see here, people coming in with a baseline of anxiety and depression around an 8 and 9, and that dropping over the course of their time with us, so in about a 9-month period. Physical activity is another thing that we focus on. And so the average of people coming in would be around 3,451 steps as a baseline. And you can see over that 12 months is an increase up to almost 6,500 on average. And again, weight loss of 4.18 kilograms, which is about 9.22 pounds on average. And this is just a little bit about what some quotes from individuals, well, actually from one of our family physicians in Burnaby and a nurse practitioner, and some things from clients that they've shared once completing the service with us as well. Yeah, I think one that I'll just read. Be Well has been a tremendous help to have the ongoing support, brainstorming, listening and talking. It's been comforting and gives me a sense of direction, options, helps with coping with stressors, accessing other resources, gives me hope, which I didn't have. I'm so appreciative and hopeful. And that I would say is a very common, a lot of people come in at the beginning a little hesitant, a little unsure of what to expect, which is very normal and natural. Sometimes expecting just another, fitness, diet program, but really coming out at the other end with, feeling a lot more skillful about, making more informed choices, and really learning that, that empowerment to be able to handle different situations and live life with a little bit more ease and trust in themselves, having more energy to do things, living more in line with their values, as Dr. Wong was talking about. So it's always really exciting to hear people when they come in and then reflect back when they complete. It's quite a journey, and it's quite an honor to be supporting individuals on that journey. And so we definitely encourage you to reach out to your primary care provider if you are interested. If you think that it's something that you might want to participate in, please find out more information. I think Leona was also going to send out some information on our service, and you can find us on the PCN website as well. And if you reach out to your physician and they aren't sure either if it's something that's right for you, as clinical lead, I'm very happy to have consults with you and your physician. So just that's always an option, that your physician can call me directly and we can have a chance to talk and see if you feel like this is something that's right for you.
That's great. Thank you so much, Michelle. That was wonderful. So just so we wrap up on time, I have a couple of questions here from folks. Well, first of all, I have a comment from Emily, who says, where does one have to reside to have this wonderful, caring doctor so willing to work in partnership with patients? So I think that's a shout out to you, Dr. Wong. You're great. So people like to acknowledge that. So thank you, Emily. Somebody would like to know actually where somebody has to reside to be a patient of this wonderful, caring, and very aware doctor. So that's two in a row. Kudos to you. So Dr. Wong's panel, I believe, is full. He's not taking any more patients, but we do have other great doctors in Burnaby. So if you live in Burnaby and you don't have a doctor, make sure you get yourself added to the wait list. Did you have any comments, Dr. Wong?
Yeah, I have a huge practice. So an average family practice is 1,200 patients. So family doctors call those panels, but mine is 2,700. So I'm working, long days. Normally this time I'd still be working on tasks after wrapping up at 6 o'clock. So after 8 hours consulting and talking to patients, then I'm doing tasks for 3 hours every day and 8 hours on the weekend. And this Saturday, I'm going to be talking to patients in the morning and then doing tasks for the rest of the weekend. So it's a big commitment, but Burnaby is quite unique. In fact, younger doctors are moving to our community because we're doing a lot to support and mentor them and to set them up. So you have your best odds finding a doctor in Burnaby compared to other cities in BC. It's much worse on Vancouver Island.
Exactly. So I do have a question from Monica. She says her GP says she's pre-diabetic. She drinks smoothies every day with half a banana, blueberries, and 1 fig. She loves to eat sweet fruit such as persimmon in season, one apple after lunch or dinner. Is that dangerous if I eat too much sweet fruit every day? And she sends her thank you.
As I mentioned, fruits are good, and depending on the extent of your intolerance or your inability to manage the blood sugars with prediabetes, then the portion sizes are important. So having one portion of fruit, like one fruit, or equivalent like half a cup of berries per meal, or for your snack in the middle of the morning or middle of the afternoon, probably is okay for people that already have diabetes. If you had a glucose monitor, you could actually check to see if your blood sugars 2 hours after eating that is less than 10, then that would still be a safe level. But as I mentioned, most people who don't yet have a diagnosis of diabetes probably wouldn't have a monitor. And even people that with type 2 diabetes don't need to monitor themselves all the time. But it is really useful to make sure it falls in those safe ranges for blood sugar management when you're making changes to your diet.
Right,
So
excellent.
yeah, I eat 3 apples a day myself. So, but I space them out. I don't have apple juice, and I don't grind them all down and eat them all at once.
Excellent. This is from Craig. How can a person who's used to visiting an indoor fitness facility reasonably get exercise without exposing themselves to COVID, RSV, or the flu, or freezing in the cold, or slipping and killing themselves on icy ground?
Yes, you can learn to exercise with an N95 mask. So that's what I do when I go to the gym at Bonser. So most of the time I go when it's really quieter. So go at less busy times, washing your hands carefully, wiping down machines before and after you use it in consideration of other people as well. And doing the N90. I even skied a whole day in Whistler wearing an N95 mask too. So you can get used to it, especially when you're used to wearing it 10 hours a day. You can get used to it as well. So going to gyms that are less busy at the quieter times and getting used to wearing a good face mask. The surgical mask is not really enough. It's good for preventing colds and the flu, but an N95 mask or a KN95 mask is probably the safer option if it's fit properly to prevent you from getting COVID. And Summit Tools in North Burnaby, my dad's favorite tool store, has had these really inexpensive KN95 masks, like $8 to $10 for a box of 20. So they're really cheap, and you can use them a number of times until they get soiled or dirty. So there's much cheaper effective masks as well. And I also returned to the pool when it reopened in January last year, because I know how hard it is when you have such a good routine and then the pandemic makes a big mess of it. So there's some pools with big wide lanes like Bonser, where you're not getting too close to people. Be careful with the showers where you're close to other people and the change rooms. So you might want to wear your N95 mask when you're changing as well, and not shower when it's really crowded. But a warning, if your N95 or surgical mask gets wet, you can't breathe through it. So I've learned that before. Also looks really silly, but you can't breathe through it when it gets wet.
Good tip. Right, I'm gonna write that down. Awesome. So Roland he would like you to advise on veg juicing, example carrots, for those with healthy blood sugar.
Yeah, so if you don't have a problem managing blood sugar, then eating lots of carrots is good, but carrots tend to be higher in glycemic index for people that do have type 2 diabetes or prediabetes. So it would be in that GI diet book that will give you a clue of it. But if you don't have diabetes, you can tolerate it. And I know Roland's a longtime patient, and he's an avid cyclist. So he's going to burn off those carrots in less than 30 minutes into his ride. So I think those of us that need calories for our exercise, I think that's a good option for you. But it wouldn't be as suitable for someone that does have diabetes.
Right. So Nancy asked this question, and thank you, Michelle, for helping her out there, but I think it's valuable for the rest of the crew that's online. She asked, is Be Well completely tailored to my own lifestyle, culture, and chronic conditions? So we'll let Michelle take that one.
Absolutely. Yeah, so when we first start working with somebody, we always take the time to really get to know you, try to understand where you're coming from, what your unique situation is, we have you start recording and observing your own patterns as well. And so we really take into account, so we try to create this whole story, and through understanding what, reviewing things like nutrition and physical activity and the different things, together, we really try to figure out what is reasonable for you, right? Again, we're all unique and have different backgrounds and different genetics, and so we want to be taking all of those pieces into consideration. We're not going to tell you, we don't actually prescribe what to do. We look at, what are some of the things that you're doing right now, try to come up with some patterns that or behaviors that you're interested in changing, and we collaborate and support you in trying to figure out what would be meaningful for you and realistic, right? And we start small and gradually build on that. But again, really, it's about you setting your own goals, and we're here to support you in doing that and provide you a little bit of guidance and structure to do so.
That's great. Thanks, Michelle. And so our last question is a thank you to everybody for the informative presentation, and a question on your thoughts on intermittent fasting, 16 hours daily for those at risk of diabetes due to family history.
As I mentioned, that's not the ideal for diabetes or prediabetes, just because we want to even out the blood sugars throughout the day. So intermittent fasting for a lot of people helps them to lose weight. So if it's done kind of for the short term so that they can lose abdominal fat and then reduce their risk, I think it's appropriate for the short term. But if they do develop diabetes or have what we call glucose intolerance, like that prediabetes, then we probably would avoid that and try to space out our calories evenly with low glycemic index meals throughout the day.
Excellent. Well, that did it. We covered all the questions have been answered, no more popping in. So I think we can call it. And we're actually 3 minutes early. For those of you who have participated in these talks before, we do have a short survey at the end as soon as I close off the session. Just a few questions will pop up. Please take the time to answer the questions, because that feedback is really helpful for all of us as we plan our program going forward. And don't forget to sign up for our next talk, which is on December 8th, Keys to Positive Change. So as we go into the Christmas season, just a little reminder of how we might avoid the pitfalls of diet and lack of exercise.
Yeah.
Dr. Wong, anything else?
Yeah, the next talk is a real deep dive into achieving your goals, whatever they might be. So it's actually an enhancement of what we talked about at the end of my talk about choosing your goals. So some of the keys of establishing healthy habits, using keys from those new books, Atomic Habits, and I might introduce a few of my tips to teach you a little bit about self-hypnosis, because I also teach healthcare providers hypnosis as well. So how to program your subconscious to develop new healthy habits and a positive outlook. So include a lot of tips that you won't get anywhere else. And really appreciate the talk by Michelle, because I've referred a number of my patients to the Be Well program, and they've really benefited from that. And it definitely is tailored to the individual and to their personal goals. And it's great that they have support for such a long time and then gain their confidence. So thanks for that. Good work, Michelle, and a great presentation. And thanks again to Leona for being the backbone of our Empowering Patients program, making it all possible.
It's my pleasure. I love it. I love it. So thanks for everybody for joining us. Please join us again, and yeah, be safe tonight. Take care.
Thank you so much.
Yeah, be well, everyone. Take care. Bye.